Okay, so now that we've looked at the neurological screening of the body, we're going to take neurological signs and symptoms and put them to the muscles of a specific place in the human body, which is, in this case, the eye. The first muscle we look at is the medial rectus muscle. This originates on both upper and lower limb of the common tendinous ring of the optic nerve sheath, one of the main nerves of the eye. Also, fascial expansion from muscle sheath forms the medial cheek ligament and attaches the medial wall of the orbit, where the eye sits. Innervation is via cranial nerve 3 or the oculomotor nerve, and the specific branch runs along inside of the cone and on the lateral surface. So in this picture, you see the medial rectus on the right side of your screen, where it connects on the eye, also with the other muscles we will cover. The lateral rectus originates on both upper and lower limb of the common tendinous ring, and the process of the greater wing of the sphenoid bone, which is one of the main bones of the skull that we look into when we look at possible problems with the eye or neurological symptoms. This inserts parallel to the medial rectus, 6.9 millimeters from the cornea. Fascial expansion from this muscle sheath forms the lateral cheek ligament and attaches to the lateral wall of the orbit at Whitnell's tubercle. Lateral rectus innervates by the abducens nerve, this is cranial nerve 6, which enters the muscle on the medial surface. The lacrimal artery and nerve run along the superior border of the muscle, and the abducens nerve, which is the ophthalmic artery and ciliary ganglion eye, medial to the lateral rectus and between the optic nerve. The superior rectus originates on the superior limb of the tendinous ring and the optic nerve sheath. Muscle passes forward underneath the levator muscle, but the two sheaths are connected, resulting in coordinated movements, so the movements go together. Okay, the frontal nerve of the superior rectus runs above the frontal nerve runs above the superior rectus and levator. The nasociliary nerve and ophthalmic artery run below it. The tendon for insertion of the superior oblique muscle runs below the anterior part of the superior rectus. And innervations via superior division of cranial nerve 3 or the oculomotor nerve from the inferior surface, and additional branches make their way to the levator. Actions of the superior rectus is elevation of the eye, but since the insertion of the globe is lateral as well as superior, contraction will produce rotation of the vertical axis towards the midline, so both lateral movement and towards the midline of the body, the eye is supposed to move, but if there's problems with this muscle, then it will not move that way. Thus, secondary action is adduction, which is moving towards the midline of the body. Finally, because the insertion is oblique, contraction produces torsion, nasally intorsion, so towards the nasal bone. Okay, so this is above view of the eye and the muscle. The muscle is the most middle one here. Because the muscle runs at an angle to the Frick's axis, contraction is confined to one axis, so it only moves on one axis. The inferior rectus originates on the lower limb of the common tendinous ring and is parallel to the superior rectus, making a 23-degree angle beyond the sagittal axis. It's also innervated by the inferior division of the cranial nerve 3, which is the oculomotor, and it runs above it. Below is the floor of the orbit and inferior oblique. The fascial attachments below attached to the inferior lid coordinate depression and lid opening. Fascia below inferior rectus and inferior oblique contribute to suspensory ligament of Lockwood. The primary action is downward gaze or depression. The superior oblique, its anatomical origin is on the lesser wing of the sphenoid bone, which I said was one of the main skull bones looking at the eye. The physiological origin is the trochlea, cartilaginous U on the superior medial wall of the orbit. This is the longest, thinnest eye muscle. The muscle ends before the trochlea. Innervation is by cranial nerve 4, the trochlear nerve, and posterior in the orbit. The action is intorsion or rotation of 12 o'clock position towards the midline, so the middle of the body. Because the insertion of the oblique muscle is in lateral, posterior quadrant of the secondary actions are rotating the back half of the globe from lateral to medial, so abduction, or moving towards the outside. The inferior oblique originates on the maxillary bone inferior to the nasolacrimal fossa, the only eye muscle that originates in the anterior of the orbit. This inserts on the posterior lateral aspect of the globe, mostly inferior, and below anterior posterior horizontal plane. Innervation from inferior division of cranial nerve 3 or the oculomotor nerve inserts on the upper surface. So here you see the bone, the skull bones, and the origin of the inferior oblique and where the trochlea is. Also, where this muscle and tendon connect. Actions of inferior oblique is primary extorsion. 2 degrees is due to posterior, lateral, and inferior insertion being pulled around underneath the globe and toward the inferior insertion medially. So it has a rotation about the z-axis with nasal and temporal or abduction, and rotation about the x-axis would be elevation of the eye. So now let's look at the eye simulator. This is a great tool. So what you see here is you see the eyes right here moving, and it will show you. So if you click on these boxes down here, let's damage the superior oblique. So we see the movements of the. If you're looking at the screen on the right side, you see the right eye moves down a lot farther than the left eye. So that's why that muscle is a little bit more damaged, because it's that movement of the eyes going down. Okay, you could do both eyes of these. Let's look at the inferior rectus. Okay, normal eye movement that way. Now you see a little difference in the left eye. You see it moving a lot farther in adduction of the right eye, and the abduction of the right eye is impacted. So if we take and we do the cranial nerve 3, you see the eyelid drop, and you see the eye has less movement, like it has no movement or the right eye has no movement such as the right eye here. Okay, so on this, although the simulator is great to use, we can do quiz mode, and it will ask you questions. Also, you can look at the eye theory, so it will tell you all that I just told you, and on different websites. So play around with this, know it. It's a great tool, and it will help you learn for the future, and also practice the muscle involvement as well as nerve involvement.